You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from the Heart.org Medscape Cardiology, and this is This Week in Cardiology for May 24th, 2024. This week, we're going to talk about clues on which patients with subclinical AF to anticoagulate, a DOAC antidote study, another negative thrombolytic trial in stroke. The Journal of the American Medical Association sparks change in observational studies, and guidelines are challenged in acute stroke care. First is an ARTESIA Substudy. The ARTESIA investigators presented a late-breaking clinical trial at HRS looking at the relationship between CHA2DS2-VASc score and stroke risk and apixaban effects on stroke and systemic embolism. Now, before I tell you about this sub-study, let's briefly review ARTESIA. The main ARTESIA trial randomized patients with devices who had short-duration AFib to either apixaban or aspirin. The primary endpoint was stroke and systemic embolism. The average age of the 4,000 patients was 77 years, and the mean CHA2DS2-VASc score was 3.9. Median duration of AFib episode was short at 1.5 hours. Only 20% of patients had AFib longer than 6 hours. Stroke or systemic embolism in the main trial occurred in 0.78% versus 1.2% per patient year, apixaban versus aspirin. The difference of only 31 strokes in a trial of more than 4,000 patients yielded a statistically significant relative risk reduction of 37%. The hazard ratio is 0.63 with confidence interval 0.45 to 0.88 and a highly significant p-value. The safety endpoint in the main trial occurred in 4.3% of patients in the apixaban arm versus 2.3% in the aspirin arm. The difference of 39 excess major bleeding events yielded a relative risk of 80% higher, 1.80, and a highly significant p-value and confidence intervals ranging from 1.26 to 2.57. At the European Heart Rhythm meeting in April, ARTESIA investigators presented a provocative sub-analysis finding no relationship between the duration of subclinical AFib and apixaban effect over aspirin. That was a bit weird because you'd expect oral anticoagulation benefit in longer duration episodes. One problem, though, with sorting out signal in ARTESIA and NOAA trial was the extremely low event rates. This analysis, which was simultaneously published in JACC and presented at the Heart Rhythm Society meeting, assessed the difference in stroke and systemic embolism and major bleeding based on CHA2DS2-VASc score. The authors made 3 groups with about a third of patients in each. One group was CHA2DS2-VASc less than 4, one group was CHA2DS2-VASc equal to 4, and the third group was CHA2DS2-VASc greater than 4. For the less than 4 group, there was no difference in stroke or bleeding with apixaban or aspirin, and stroke rates in this group were about 0.9% per patient year. For the equal to 4 group, the rate of stroke on apixaban versus aspirin was 0.54 versus 1.2% per patient year, but this difference did not meet statistical significance, and the same with bleeding rates. The difference there did not make statistical significance. It was 1.2 with apixaban versus 0.9 with aspirin. The key finding of this paper came in the greater than 4 CHA2DS2-VASc group. Here, the rate of stroke with apixaban was statistically significantly lower than the aspirin group. Basically, it was 1% versus 2.25% per patient year. That hazard ratio came out to 0.44 with confidence intervals 0.25 to 0.77. Bleeding rates were similar, 2.1 versus 1.5% per patient year. That difference did not reach statistical significance. The authors converted these relative risk reductions and wrote, quote, in this group of the greater than 4 CHA2DS2-VASc group, over a period of 3.5 years, apixaban prevented 4 strokes and systemic embolisms per 100 patients compared with aspirin, and it caused 1.70 major bleeds. However, they did an interaction p-value to assess whether these differences between low, moderate, or high, very high CHA2DS2-VASc scores was statistically significant, and the p-value for interaction came out at 0.06. So technically, not significant, but very close. These findings caused the authors to be quite strong in their written and spoken conclusions. They felt like subclinical AFib in patients with CHA2DS2-VASc score that were high and greater than 4 warranted oral anticoagulation. They cited the 1.2% absolute risk reduction in stroke. They cited the lack of significance in the higher rate of bleeding in this group. They also cited a previously published sub-analysis from ARTESIA in which patients who had had prior stroke also benefited from apixaban versus aspirin. That analysis was presented but not yet published found that the risk of stroke and systemic embolism among aspirin-assigned patients who had a history of stroke or TIA was 3.1% per year, and to them that suggested that oral anticoagulation should be recommended for these patients, even if their CHA2DS2-VASc score was less than 4, that is, patients who had prior stroke. So my comments. The conclusion that we use oral anticoagulation in subclinical AF when CHA2DS2-VASc is greater than 4 makes good sense, but I worry about the strong conclusions from this subgroup analysis paper. I mean, what if a patient has 1 hour of AFib over months? Technically, that's actually subclinical AFib. But is that really enough AFib? Subclinical AFib, I think, comes in many different varieties. Now, we always need to remember that trials are powered for their overall results. ARTESIA was a positive trial for stroke reduction, but this very small absolute risk reduction was balanced by a similarly sized increase in major bleeding. So I consider ARTESIA, especially when combined with similar results of NOAA, inconclusive. 2 trials, and we still really don't know what to do with these patients with subclinical AF. Now, ARTESIA authors want us to be certain about higher risk patients, and I agree somewhat, but I'm not totally convinced. For instance, ARTESIA authors also cite a NOAA sub-analysis based on CHA2DS2-VASc score, but the NOAA subgroup analysis did not find the same heterogeneous treatment effect. The other thing I worry about here is the degrees of freedom of this analysis. They split the subgroup into 3 groups. What happens if you split the subgroup into 2 groups or 4 groups? We don't really know. And the event rate in the main trial was low, about 1.5% per year. Now, when you carve this up into 3 groups, the power goes down, the signal-to-noise ratio goes up. I still think we have a lot of uncertainty about subclinical AF. Yes, as CHA2DS2-VASc goes up, stroke rates are higher. The benefit of the apixaban is more likely, but I don't think we can apply an algorithm. Subclinical AFib with CHA2DS2-VASc score greater than 4 always means DOAC. I think there's still uncertainty. All right, second topic today is a DOAC reversal trial called the ANNEXA-1 trial. I like the story of anticoagulation reversal agents. It's a good canvas for thinking and testing that which makes sense. You have to move past first-order thinking. What makes sense here is that if you have a patient on a DOAC who has an intracranial bleed, that's the most serious kind, it makes sense to reverse the anticoagulant. Brain bleeding that continues can be devastating because of the intracranial pressure, so get the anticoagulation reversed goes this first-order thinking. Yet, you can't just magically reverse systemic anticoagulation without creating a procoagulant situation systemically. And that is why you need proper trials. The ANNEXA-1 trial is such a trial. But, you have to be careful when you read this trial, and you have to go beyond the primary endpoint. Here are the details of the trial. a total of 263 patients who had intracranial bleeding were randomized to receive the reversal drug, annexonate, and 267 received usual care. Now, usual care included prothrombin complex concentrate that was given in about 85% of the control patients, though there are no RCTs that I know of showing that this is an effective therapy. The authors chose a composite primary endpoint of three things. They first chose hemostatic efficacy as defined by expansion of the hematoma by 35% or less, an increase in the stroke scale called the NIHSS scale by less than 7 points, that's a 0 to 42 scale, and also no receipt of rescue therapy like, say, surgical drainage. Hard clinical endpoints like death or outcomes was secondary or safety endpoints, and as you will see, the story of this trial resides in the secondary endpoints. Now, the final results for the chosen surrogate endpoints, the drug annexonate worked. The overall hemostatic efficacy was superior in the annexonate group. It was 67% versus 53%. The absolute better rates of the primary endpoint was 13 percentage points, and the p-value was significant at 0.003. This composite of hemostatic efficacy was driven mostly by better outcomes in the hematoma expansion arm. Now, more in the annexonate group had less than 35% expansion. That was 77% versus 65%. For the other two components, the NIHSS scale and no receipt of rescue, the rates were fairly similar in both arms. As for safety or secondary endpoints, there were more thrombotic events in the annexonate arm versus usual care. It was 10.3% versus 5.6%. That's nearly twofold more. Ischemic stroke occurred in 6.5% receiving annexonate versus 1.5% receiving usual care. That difference of 5 percentage points, 95% confidence intervals went from 1.5 to 8.8. Myocardial infarction occurred in 4.2 versus 1.5%, and there were no significant differences in overall death. There were also similar numbers of patients in both arms, 28 versus 31%, who had acceptable neurologic functioning at 1 month. Now, my conclusions. I think this is a definitively negative trial. While there was a positive primary endpoint, that is less hematoma expansion, clinical endpoints looked far worse for the drug. For every 100 patients treated, there were 5 more thrombotic events, including 5 more ischemic strokes and 3 more myocardial infarctions. And at 1 month, there was no difference in death, nor the number of patients who had achieved acceptable neurologic function. What's more, the projected cost of annexonate is $22,000 per dose. So in summary, I love this trial because it shows that even though a drug can have a favorable effect on one thing, that is hemostatic efficacy, it may not improve overall outcomes. And now we've seen that before, right? Say PVCs after MI. Antiarrhythmic drugs made the PVCs go away, but patients died at a higher rate. So I think the message here is it takes a lot more than one thing for a drug to do to make a person function better or live longer. I really like the Nexa-1 trial for its messages. The first message is obviously for patients with intracranial bleed. I can't see any benefit of giving this $22,000 drug. But more generally, the Nexa-1 trial shows how important it is to study clinical outcomes even when there are strong, plausible mechanisms that the drug should work. All right, next topic. Speaking of complexity of drugs beyond their designated job, we should talk about another negative thrombolytic trial in the acute ischemic stroke space. This is called the TEMPO-2 trial. This was thrombolytic therapy in acute stroke, and TEMPO-2 was tenecteplase versus placebo in patients with mild stroke and intracranial occlusion or focal perfusion defect. Now, tenecteplase is similar to alteplase, but it has a longer half-life, it is more fibrin-specific, and it results in less systemic depletion of circulating fibrinogen than alteplase, so it has potential advantages. Now, the idea for patients with mild stroke is, as the authors write, that these patients are at higher risk for neurologic deterioration, which most often occurs within the first 24 hours after presentation. What's more, this subpopulation were excluded from most of the trials of thrombolysis and are not given lytic therapy. Now, the average NIHSS score was only 2, so these were quite mild strokes in this trial. Nearly 900 patients were randomized in Tempo 2. The primary outcome of return to baseline functioning or pre-stroke modified ranking scale at 90 days occurred in 75% of patients in the control arm versus 72% in the tenecteplase group. That risk ratio hovered around 1. It was 0.96, and the confidence intervals went from 0.88 to 1.04, p-value 0.29, so not significant. Tempo 2 was actually stopped for futility, so it seems like a wash. In addition, tenecteplase recanalized arteries. So for patients with large vessel occlusion, recanalization rates in the drug arm were 49% in the tenecteplase group and 13% in the usual care group, and that was highly significant. But this trial really wasn't just a wash. Death occurred in 5% versus 1% in the tenecteplase versus control arm. That's a hazard ratio of nearly 4x for the drug. Symptomatic intracranial hemorrhage occurred in 8 versus 2 patients in the tenecteplase versus control arm. 7 deaths, 1 in the control group versus 6 in the tenecteplase group, were related to symptomatic intracranial hemorrhage. And the authors write that the theory was that the presence of an intracranial occlusion would define a minor stroke population that would have worse outcomes and benefit from reperfusion therapy. But it did not work out, did it? Not at all. And I want to make a note here on the rate ratio and the confidence intervals of the primary outcome. I note it because you don't often see these tight intervals very often. The rate ratio here was 0.96, and the confidence intervals went from just 0.88 to 1.04. I never know what the stats professors will say is the threshold for saying a therapy doesn't work, but there seems to be very tight confidence intervals here. And you can add to that tighter confidence intervals that there was a higher death rate, in large part due to higher rates of intracranial hemorrhage. So I think we can say that lytic therapy ought to be avoided in patients with minor stroke symptoms. And this was despite the fact that the drug did what it was supposed to do. It recanalized the artery 4 times more than the control. Now, I realize that most listeners are not stroke neurologists, but I think this is a notable study for its clear harm more than benefit signal. I also steadfastly remain doubtful about the entire lytic frame for acute stroke. I will link to my old essay on that topic. And if I had one wish for a repeat trial in medicine, I would love to see the original NINDS, NINDS trial repeated. That trial had clear differences in baseline characteristics, which may have driven the positive results and really started the whole thrombolytic therapy in acute stroke enterprise. All right, next topic, observational research. As I have spoken about so often on this podcast, the best way to understand causation is randomized controlled trials. Treatment A versus treatment B are presumed to have equipoise. Experts disagree on which one is better. Then knowledge is gained by letting randomization choose and then looking forward to the results of a given endpoint. If you do the opposite, if you let clinicians choose one or the other treatments, and then you look back at the results, you can be fooled because clinicians use lots of factors to decide treatment. Some of these factors can easily be controlled for and adjusted for because they show up on a data sheet. Things like age, blood pressure, diabetes, smoking, etc. But many factors, the patient's demeanor, their home situation, etc., play into treatment decisions, and these factors cannot be controlled for because they don't show up on a data sheet. And that's one of the main problems with non-random comparisons, namely unknown variables that drive results instead of the treatment or exposure. Randomization is so beautiful because it balances both known and unknown variables. Now, once again, I'm recording in a hotel room. In a couple of hours, I will have a lecture at the Beth Israel Deaconess Medical Center here in Boston. This group is famous for their leadership in ways to sort out causation from non-random studies. I will confirm tomorrow, but I bet even they would admit that even with advanced methods to emulate trials, there is usually a greater risk of bias in non-random comparisons. Okay, this is a long intro into a quite provocative policy change at JAMA, the Journal of the American Medical Association. Early as this month, the editors of JAMA wrote a special communication in which they have changed their approach to observational research. Like many journals, JAMA has strictly forbidden causal language in the reporting of observational studies. Descriptive verbs are such as associate with are the ones that are favored. Now, though, they're going to allow the truth to come out. When the authors look back and observe the effects of two non-random treatments, they will now be allowed to say what they're actually doing, and that is they're trying to determine cause, not just correlation. JAMA editors will ask authors to address 6 core questions of observational studies. What is the causal question? What quantity would, if known, answer the causal question? What is the study design? What causal assumptions are being made? How can the observed data be used to answer the causal question in principle and in practice? And the 6th one, is a causal interpretation of these analyses even tenable? Ultimately, the editors of JAMA write that there will be 2 main elements of an observational study. First, investigators must be explicit about the if-then conditional structure needed for their interpretation. For example, if certain assumptions hold, then a causal interpretation of the findings is tenable. And the second factor, acknowledging that careful, context-informed judgments are necessary to evaluate whether assumptions are plausible and a causal interpretation is tenable. The editors of JAMA then write, the framework does not imply that all or even most observational studies merit a causal interpretation. For some observational studies that start with a causal goals, causal inference may prove impossible, and in these cases, estimates remain only associational interpretations. Now, I've discussed this policy change with a number of academic colleagues, and many think it is a bad idea. They worry that it will lead to even more biased conclusions and potentially faulty conclusions. These colleagues tell me how easy it is to do low-quality database-type research. But, I may be totally wrong, but I think this is a decent idea. I am less pessimistic. Here is my thinking. Yes, while some observational research is designed to describe things such as trends over time or prognosis, procedural complications, much, if not most of it, is comparative research looking for causation. Nearly every non-random observational comparison study is actually doing causal research. Authors tally effect sizes, they make adjustments, they do their best to sort out biases, and they try and emulate or simulate randomization, all in an effort to sort out causation, not just correlation. But then, when they find different effect sizes or harms, journals makes them hide their true effort with language. They force authors to write, it's an association. Yet everyone knows what the authors mean and what their goals are. The goals are not to report associations. The goal is to say something about causation. JAMA will now allow such language, but in doing so, I hope they will also force more rigor into the methods of why and how the study shows causation. I like this because in the past, every observational study was considered the same. There were lines written in the paper like, quote, this is not randomized, so we cannot exclude residual confounding. I'm sorry, but that line doesn't help because it is a given, and it basically makes everyone happy. Those who want to find causation feel like the line relieves them. We said it, now look at our findings. To those who see no possibility of causal inference, people like me, for instance, we can say, see, they wrote that residual confounding is likely and we can't conclude anything. Now, maybe with this new policy change, we can read why the authors think their findings are more than just correlations. It's also possible that the entire observational research enterprise gets a boost. We shall see. Last topic, briefly. Speaking of decent observational research that may sort out a causal question and challenge guidelines, let me enter again the acute ischemic stroke space. This is a study on active and aggressive blood pressure control in stroke. Here's the story. Some patients with acute stroke have very high blood pressures. guidelines recommend IV drugs to reduce blood pressure so that patients can get lytic therapy. That's because lytic therapy is contraindicated when there's super high blood pressure. It turns out that there is little data for this strategy of aggressive blood pressure lowering. In fact, there are potential harms in the setting of acute stroke. So Dutch authors had the idea to test this question, and they used a quasi-randomized observational design. This was the TRUE study, and it used a cluster design wherein 37 Dutch centers either adhered strictly to the active blood pressure control strategy or it did not. Patients in the study had to have a high blood pressure greater than 185 over 110, and they were otherwise eligible for lytic therapy. The primary outcome was functional status at 3 months. Over about 7 years, they recruited 850 patients from 27 centers that followed the active blood pressure treatment arm. The control arm had only 200 patients from 10 centers that followed a non-lowering strategy. In the active blood pressure arm, 94% of patients were able to receive thrombolytic therapy with a door-to-needle time of 35 minutes. But in the control arm, only 52% received thrombolytic therapy with a longer door-to-needle time of 47 minutes. And the results. The adjusted odds ratio for a shift towards a 90-day functional outcome was 1.27. Confidence interval 0.96 to 1.68. That's for the active blood pressure reduction compared with no active blood pressure reduction. So no statistical difference and kind of a strong trend toward worse in the active blood pressure control arm. Intracranial hemorrhage occurred in 5% versus 3% of the two groups, and obviously that was not statistically different. The author's conclusion is good. Let me read it to you. Quote, insufficient evidence was available to establish a difference between an active blood pressure lowering strategy in which antihypertensive agents were administered to reduce blood pressure below 185 over 110 and a non-lowering strategy for the functional outcome of patients with ischemic stroke, despite higher IV thrombolysis rates and shorter door-to-needle times among those in the active blood pressure lowering group. They write, quote, randomized controlled trials are needed to inform the use of an active blood pressure lowering strategy. So my comments are, see, observational studies can be done to give signals of benefit or harm. This is a pretty strong design. The authors make excellent conclusions. In the end, they say there is still insufficient evidence to warrant aggressive blood pressure control in acute stroke. There was insufficient evidence before, and now there is still no signal of benefit after this observational study. I would say it's even a stronger signal towards harm, and they call for RCTs. And they note in the methods section that RCTs have not been done because doctors have not been willing to consider not aggressively controlling blood pressure and or giving less thrombolytic therapy. And so I love this observational study because it was done to bust up the lack of equipoise and prove the necessity of an RCT. The paper is in Lancet Neurology, and Medscape has a nice story on it. Take a look at it. Okay, that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to give us a rating and a review. Those things go a long way to helping others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.